This concept of the glycocalyx is relatively new, but it's incredibly important, I think, for us to understand how to prevent and also treat cardiovascular disease. Most of us have been very attuned to the role of the endothelium, and the glycocalyx is really very similar into its effects, the things that it does to prevent cardiovascular disease. And many of the compounds that are produced by the endothelium are also produced by the glycocalyx. This distinct difference, though, is the glycocalyx is like a first line of defense. It's a bare coat, so to speak, or a sugar coating on the outside of the endothelium. So if the glycocalyx becomes damaged, it allows a lot of the environmental influences in the blood to slip through the glycocalyx and then cause endothelial damage. So some new terms for our discussion. We all know about ED, which is endothelial dysfunction. And today we'll add the new concept of GD, which is glycocalyx dysfunction. You can see here what the glycocalyx looks like. So there it is, just attached to the endothelial lining. And in the electron microscopic view, you can see it's hair-like projections that stick out from the endothelial lining into the lumen. And these are the protective coating then that allow protection of the endothelial lining. It's a very smart barrier. It's very selective, so not everything can sneak through there, particularly cholesterol, platelets, and leukocytes, to avoid sticking to the vascular endothelium. It's very thin, and the thickness will vary depending on which artery it's in. It has antioxidant properties, particularly SOD, and it also keeps nitric oxide levels up very high. It regulates permeability, inflammation, coagulation, and also fluid balance. And it's a transducer related to shear stress, to blood flow and blood pressure, which in turn increases production of nitric oxide. If one looks at the components of the lumen, the blood elements, these are all familiar to all of us. But what happens if the leukocytes and platelets and other circulating components of the blood sneak through this glycocalyx lining, past all the sugar coatings, and we'll talk about what's actually in here shortly. And then it gets into the endothelial lining and then to the subendothelial layer, then that sets off the first step for atherogenesis and coronary heart disease. This is the actual structure, glycocalyx here, attached again to the endothelium. You've got the endothelial permeability barriers, the junctional complexes, and of course, all these subregulators here for the three finite responses, which are inflammation, oxidative stress, and vascular immune dysfunction, and everything in the subendothelial layer, which sets off the enzymatic and problems with atherosclerosis and CHD. Particularly related here is cell adhesion molecules, which are one of the first steps with the leukocytes and monocytes adhering actually to both the glycocalyx, but also as the endothelium. So what is the glycocalyx? It's proteoglycans. There are 7 types. These are long chain glycosaminoglycans, or GAGs, with various side chains, particularly heparan sulfate, which composes from 50 to 90%, but also it has chondroitin sulfate, dermatan sulfate, keratan sulfate, and hyaluronic acid. And it also has glycoproteins. And these are the things that we're all familiar with, like CAMs, selectins, integrins, and immunoglobulins. And all these are going to bind to endothelial cell. It's the backbone for these two very important structures. There's what are called soluble proteoglycans, thrombomodulin, superoxide dismutase, and antithrombin 3, which all relate to oxidative stress protection and also to coagulation disorders. So it helps to limit access to the endothelial cells, protects them, also reduces access to lipoproteins, particularly LDL and Lp(a), activated platelets, as well as sticky leukocytes. The main function of the glycocalyx is to regulate the microenvironment. So all the 3 finite responses that we'll keep referring back to, which are inflammation, oxidative stress, and vascular immune dysfunction relate to many of the things shown here, like antithrombin 3, tissue factor pathways, lipoprotein lipase, vascular endothelial growth factor, superoxide dismutase, and then finally hyaluronic acid molecules. And you can see there's a lot of long chains that will dangle out into the luminal area, but they're attached very heavily right here to the endothelial cell. So the signal transduction is partly due to shear stress, changes in blood flow, oscillation, blood pressure, and this can then set off damage to the glycocalyx, as well as other things that are in the lumen, like LDL cholesterol, homocysteine, and other compounds. So that shear stress then is going to determine a lot of the changes that occur, particularly at bifurcations where a lot of the atherosclerosis occurs, where the blood flow is disrupted. Now, the function of the glycocalyx actually is very similar to the endothelium, so it's not that hard to make a pretty smooth transition into understanding the glycocalyx. So it's very important in production of nitric oxide, and therefore it helps to decrease endothelial dysfunction, lowers blood pressure, and reduces atherosclerosis. The shear stress sensors, the superoxide dismutase, serves as a barrier to LDL cholesterol as well as Lp(a). The electrostatic charges also help to hinder vascular permeability. There's a colloid osmotic gradient, which helps to serve as a vascular barrier. It's antithrombotic, stops platelet adhesion, leukocyte adhesion, and diapedesis. It's important in rheology in the blood. Also related to fibroblastic growth factor is other tissue factors related to both growth as well as anticoagulation. There's the 3 finite responses, which it helps to inhibit. It's an interface between the blood and the endothelium and relates to mechanotransduction issues. So if the endothelium or the glycocalyx are damaged, you're going to have very similar changes in various production of vasodilatory hormones, in cytokines. So the nitric oxide level will go down. There's an increase in oxidative stress. You start to have micromolecular leakage. Then this diabetic complications ensue. You've got issues related to ischemia, reperfusion, and injury, increased platelet adhesion, thrombin goes up, leukocyte adhesion is increased, and then you end up with more CHD and atherosclerosis. This is electron microscopy. Here's the intact glycocalyx here, the vessel lumen here, and then the endothelial lining. So this would be a normal glycocalyx. However, after it's damaged, you can see that it's very much in disarray, much thinner, has escape routes into the vascular endothelial lining. And then once this is damaged, the endothelium is soon to follow. The same causes for endothelial dysfunction are also very similar for glycocalyx dysfunction. Any dysglycemic disorder, particularly metabolic syndrome or diabetes, oxidation of LDL, which stimulates leukocyte cell adhesion molecules, increases in LDL cholesterol and triglycerides, thrombin, cytokines, the 3 finite responses, hypervolemia, low shear stress, hyaluronidase, which is going to break down hyaluronic acid, metalloproteinases or MMPs, ischemia reperfusion disorders, atrial natriuretic and endotoxins, all of which cause damage to both the glycocalyx and endothelium. The endothelial glycocalyx will vary in its thickness depending on the size of the artery. And it's particularly damaged at bifurcations, which is, as you know, where most of atherosclerosis actually begins. So this is just a schematic of the high risk of plaque at these bifurcations. So you've got a healthy artery, then you have the endothelial dysfunction, and here at the bifurcations where the shear stress is altered, and you start to get all the leukocyte adhesion, platelet adhesion, turbulent blood flow, and eventually the glycocalyx is damaged, and then the endothelium is also damaged. So I think that it's important that we start to look at these two as partners in prevention of cardiovascular disease and try to enhance the compounds that improve the glycocalyx but also improve endothelial lining, and look at how we can prevent glycocalyx and endothelial dysfunction, because these are the two primary vascular events that are going to relate to early cardiovascular disease. And as has been pointed out for decades, endothelial dysfunction is the starting point of cardiovascular disease. But now we can step it back a little further and say that, well, yes, but also the glycocalyx is one of the primary protectors of the endothelium. So it now becomes very important as a starting point for CVD as well. So our goal in prevention really has to be to clearly address the treatment for both of these. And like I said, the transition from understanding endothelial function and dysfunction is not that difficult to move straight into the glycocalyx for most of us. Now, here's an interesting note that's been reported fairly recently. Well, not that recently, actually. 2011 was the first report, and then the most recent was in 2018. And it relates to sodium, the epithelial sodium channel, and aldosterone and hypertension. And the concept is fairly simple, and that is that the endothelial glycocalyx actually is a very effective buffer for sodium. And as you all know, sodium, once it gets into the endothelium, is very toxic, causes endothelial dysfunction, and helps to reduce nitric oxide levels. So if you add to that a high sodium intake, a high sodium content in the glycocalyx, endothelial lining, abnormalities in the epithelial sodium channel, which is both in the blood vessel, but also in the kidney, and then increases in aldosterone levels, all these effects dramatically increase both glycocalyx and endothelial dysfunction, which increase blood pressure, pulse wave velocity goes up, arterial stiffness, nitric oxide falls, endothelial shrinks, becomes damaged, there's more inflammation, increases in TNF-alpha, interleukin beta, and VCAM. Then you get microcirculatory dysfunction, decreased coronary flow reserve, and abnormalities in LV myocardial deformation. The importance of this related to therapy is obviously to decrease sodium intake, but also to address specifically blockers of aldosterone and blockers of the epithelial sodium channel. Well, spironolactone and eplerenone obviously take care of the spironolactone, take care of the aldosterone issues. And there's more data now that amiloride is one of the most potent epithelial sodium channel blockers. So it's not only blocking that in the kidney, which is going to reduce blood pressure, particularly in genetic SNPs, but also is very important in the blood vessel to reduce endothelial and glycocalyx dysfunction. You have to be careful, obviously, using these two together because of potassium retention. But I think most of us that are doing a lot of hypertension have found that these two drugs, amiloride and spironolactone, have become really good mainstays, not only for sodium sensitivity, but also for resistant hypertensives. And we now have the ability to do genetic SNPs and identify patients who have genetic abnormalities in both the sodium channel as well as aldosterone production. So what are the strategies that we can use to actually regenerate the glycocalyx? Well, some of these you obviously wouldn't use or wouldn't use long term. There are others that obviously would be used. Hydrocortisone, all the calcium channel blockers are very effective. Obviously controlling glycemic issues, metformin being one of the best here. Others will be shown to be effective in the future, but we don't have as much data. This is a new one, sulodexide, which is a purified glycosaminoglycan, and we'll talk more about this and how it works to actually improve glycocalyx function. The statins work, any reduction in inflammatory mediators. There's actually some data with doxycycline in some patients where there may be an inflammatory or infectious disease issue. Glycocalyx regenerating compounds, which we'll talk about shortly, nitric oxide, albumin, fresh frozen plasma, N-acetylcysteine, hydroxyethyl starch, and glycosine 1-phosphate or CYP. This is some data on metformin and the glycocalyx. So there's three things I want to show you here. One is a control blood vessel, which is shown in A, very healthy glycocalyx and endothelium. Then we have the diabetic blood vessel. Now you can see the glycocalyx is beginning to be very damaged. You've got a lot of oxidative stress compounds. And then the diabetic blood vessel after metformin, which you can see does restore partly back to normal. So there's a lot of combinations of agents or single therapies that are very effective in repairing some of the diabetic dysglycemic issues. This is another control data looking at high glucose content that actually degrades the glycocalyx. So this is your control black field here. This is the glucose content down below in these three slides. There's your control nucleus. There's your high glucose nucleus. You can see some damage occurring here. And then here's your control glycocalyx and the high glucose glycocalyx, which shows major disarray in the glycocalyx. So glucose is a really bad actor, not just for endothelial dysfunction, but also glycocalyx dysfunction. So what we now have is the ability to actually do regenerating compounds to repair the glycocalyx. These are called GRCs, and they're made from polysaccharides, very similar structure to the glycosaminoglycans you find in the human endothelial glycocalyx. So these were very logical candidates to use in human studies. They're marine-based polysaccharides and have data, which we'll show shortly, that have cardiovascular benefits. The compound that was developed by Calroy is ARTEROSIL, and it's a specialized sulfated polysaccharide, marine-based ARTEROSIL that's been verified to regenerate both the endothelial glycocalyx and also to protect the endothelium. And I'll show you some data that can actually cause reversal or stabilization of plaque in the carotid arteries. This is some data looking at the glycocalyx repair system caused by excess glucose in vitro. So over here at the far left, we have a normal glycocalyx, and then we add a high content of glucose. You can see that the intensity drops now to damage at 81% of normal. Then we go back to a high glucose content, dosage A, B, C, D, and E. So very quickly, glucose in high doses can damage the glycocalyx. And long term, it's not just the amount, but also the duration that can damage both the endothelial lining and glycocalyx. In addition, leukocyte adhesion is very dramatic in atherosclerosis. This is a study in an animal where the glycocalyx was actually removed by microperfusion using hyaluronidase, and then introduce either saline or ARTEROSIL 45 minutes later. And the end result compound was to measure leukocyte rolling and adhesion using an intravital microscope. And here's the leukocyte response that you'd normally see in endothelial dysfunction and endothelial inflammation with stage 1, the rolling capture, the arrest and spread, and eventually the diapedesis into the subendothelial layer. And once this occurs, it's very hard to reverse, and you set off in a whole array of subendothelial diseases that result in atherosclerosis. So here's the data from the study. And this is the baseline over here. What we're looking at on the vertical column is the number of adherent cells per vessel. So we add hyaluronidase, you can see the damage is dramatically increased. Adding saline really did very little. 15 minutes after saline, nothing, and then the damage actually is getting worse. So saline didn't really do anything to improve the glycocalyx function. And this is ARTEROSIL. Here's your baseline. We add hyaluronidase, damage goes up. After 5 minutes of ARTEROSIL, the damage is decreasing. 15 minutes, a little better, and it stabilizes at 30 minutes. So the damage is dramatically reduced, and it's almost back to normal within 15 minutes, which is pretty dramatic. And it seems to stay that way with long-term treatment. So let's look at just some data about arterial elasticity and vascular dysfunction. So vascular elasticity is an indirect measure of endothelial dysfunction, because once the endothelium is damaged, vascular smooth muscle also becomes damaged. And this is a study at Baylor University, small numbers, subjects given ARTEROSIL, and then they looked at vascular elasticity using plethysmography at 30 minutes and then up to 180 minutes after ingestion. And many of you are very familiar with pulse wave analysis and plethysmography. So these are the things that are looked at: arterial elasticity, eccentric contraction representing contraction power of the left ventricle, arterial elasticity basically looking at resistance in the peripheral circulation, but also in the coronary arteries, and residual blood volume, which is sort of a measure of how well the arterial system is contracting during systole to deliver all the blood to the periphery and also to the cardiac myocardium. So in this particular study, ARTEROSIL increased arterial elasticity almost 90%, which was highly significant at different levels. Then there's a study looking at plaque regression. This is an ongoing pilot study. The data is preliminary, but it's very encouraging. Some of you may be familiar with the new plaque view. It's an MRI which looks at actually plaque morphology, which is much more accurate than just looking at, for example, a carotid ultrasound to tell you what actually is the composition of the plaque and is it prone to rupture. So these were patients that had the carotid plaques confirmed with the MRI plaque technology. Then they were given ARTEROSIL, and then they were analyzed both at baseline and 2 months after treatment. And looking at plaque vulnerability in specific. Now, most of the arterial stenosis that results in plaque rupture occurs with plaques that are sometimes 50% or less of the actual lesions, particularly in the coronary arteries. So plaque ruptures accounts for probably up to 75% of thrombi leading to MIs and up to 90% leading to ischemic stroke. And most of these are non-stenotic plaques. So it's very important for us to look not just at obstruction of blood flow, but also to plaque morphology. And that's what this MRI plaque technique allows you to do. So the vulnerable plaque is what we're going to be looking at here, which is that lipid-rich core, which is prone to rupture, hemorrhage, and then subsequent thrombosis over the plaque. So thin fibrous cap, rich lipid nuclei, and rupture prone. So this is the characteristics of the plaque view. It's now FDA approved, MRI with carotid plaque analysis, and we can look at maximum wall thickness, normalized wall thickness, and quantitation of what's actually in the plaque with lipid core, components of calcification, and also hemorrhage. So the plaque regression study that was done, it's a 2-month study using ARTEROSIL, 1 capsule twice a day, and then they did MRI sequencing, and then post-MRI 69 days after baseline. So here's your genders over here: female 65, male 65. Here's your baseline plaque, 12.6 female, 7.7% males. And here's the post-plaque at 69 days. You can see the difference from 12.6 to 4.5, highly significant, minus 64%. And in men, 7.7 to 4.1, 46.8%. Those are highly significant reductions. And what's really impressive is this occurred in about 2 months. This is probably more impressive than we've seen even with some of our powerful drugs such as statins. And it's important to see how this works with other agents, nutraceutical agents, but also nitric oxide boosters and with drugs to see if there's actually some additive or synergistic effects. So this study, although preliminary, small numbers of patients, needs to be replicated. There is some real hope here that we have a new technology now, new treatment to change the morphologic structure in carotid plaque. So we'll need some larger US-based studies, multi-center trials to see if this can be confirmed. So a lot of published data that I've shown here in using other agents. This is a rovastatin study. This was over 24 months, 25% reduction. So this was important and significant, but still not to the same degree as we've seen in the ARTEROSIL study. And here's an atorvastatin for 36 months showing a 38% reduction. So I think that, there's probably different methods or different mechanisms, I should say, by which statins work compared to ARTEROSIL. And I guess the real question is, what would happen if we used combination therapies in the future? We might get even some more dramatic results. And those studies obviously have not been done, but need to be done. So ARTEROSIL plaque regression looks impressive. 55% average reduction in lipid-rich core with improvement in stenosis as well. I showed you this slide earlier, so I won't repeat it. This is a study that we did in the Hypertension Institute. It was a blood pressure study. It was a real pilot study, very small group of patients. But what we did see is some reductions in particularly systolic and diastolic blood pressure very shortly within 3 months. So there's data to show that we can use ARTEROSIL not just for plaque morphology regression, but also some early data that it lowers blood pressure as well. So doing those two together, attacking those two risk factors, I think has great promise for reducing coronary heart disease